in order to try to solve CARS, cardio-abdominal renal syndrome. On the nephrocritical care meeting, I would like to especially thank Wilfried Mullens and Mathieu Legrand. These are my conflicts of interest, and my biggest bias being the co-founder of the Abdominal Compartment Society. This happened in 2004 in beautiful Noosa in Queensland, Australia, where we had Fox Creek Wines as a major sponsor, and while we were enjoying wine tasting breaks, we sat down and wrote the international consensus definitions, which has been one of the most cited articles in intensive care medicine. So don't be offended, this was just a present from the students and the residents, showing that I have huge bias. Whenever I ask a question, the answer is intra-abdominal pressure. So this talk will be on breaking some bad habits, and let's dive into this by illustrating CARS with a case. So I would like to present you a case of a man of 66 years old. This is previous history. So to sum up, we see a lot of cardiac problems, also had cardiac surgery, and an ejection fraction of around 29%, and is known with chronic kidney failure. So the patient was referred for a second opinion because of the progressive exertional dyspnea, and on clinical exam we see a bit tachycardic, tachypneic, low on SATs, and increased edema and jugular reflux. So to sum up, there is the dyspnea, tachycardia, tachypnea, and patient is edematous. So again, combination of cardiac problems and chronic kidney problems. So this is the chest X-ray. We can see the sternotomy, and blood gas drawn shows low PO2. So patient on top of this is in acute respiratory hypoxic failure. So the lab results come in, and we see an increased urea, creatinine, potassium, also some liver enzymes increased, and BNP, and also CRP. So again, we have maybe acute and chronic kidney failure, cardiac problems, seems to be some fluid overload, accumulation, as well as inflammation. So question is how to treat. And if we look at the regular treatment of this patient, it's traditional ACE inhibitors, some diuretics, beta blockers. And what we did is we added on top of that bumetanide as an intravenous diuretic bolus and then a continuous drip. But if we look at the result of our treatment, diuresis remained poor, 650 ml per 24 hours. Patient was still edematous in congestion, and as you can see, creatinine function further deteriorated with an increased potassium. So this definitely was not a good option, and we would have been sacked, and you probably as well. Because there are different things going on. We have the acute and chronic kidney injury, the congestion, the edema, there is some inflammation, dyspnea. So the question is, should we diurese the patient? Should we we tried it. Should we give maybe a little bit of fluids? What about intubation, ventilation? What about the inflammation? And maybe we need antibiotics. So this is a classic example of a therapeutic dilemma, which means that there are different options for treatment, but any therapeutic action may cause some harm. So the question between the dry and the wet spectrum of treatment in patients with decompensated heart failure. If we look what the Heart Failure Society of America states, so we can have either diuretics, okay, add another diuretic, stop ACE inhibitors, maybe vasodilator, inotropics, maybe we need to start mechanical treatment with dialysis, ultrafiltration, or support the heart, and if the patient is young enough, we can start transplantation workup. What we did at the time is intubate after sedation and put on mechanical ventilation and some moderate dose of dobutamine. Then go back to the patient in the ICU. We see that remains tachycardic, blood pressure on the lower hand, but the CVP is largely increased to about 17 millimeters of mercury. With the ventilation, oxygenation is getting better. But there is some crucial information missing in our patient, and you're right, as ultrasound, as the modern stethoscope, we performed transesophageal echocardiography, looked at heart valves and function, tried to estimate diastolic dysfunction, and calculate right ventricular filling pressures with the pulmonary artery pressure of about 45 millimeters of mercury. The patient has dilated atria, and there is tricuspid and mitral regurgitation. So there seems to be an issue at the right side of the heart as well. But again, something is missing here. And in fact, we performed transpulmonary thermodilution measurement with PICO device. And as you can see, cardiac index was decreased. Global endostolic volume, normal value 800, is increased, and the lung water normally should be 6-8 milliliters per predicted body weight, and there is dramatically increased. So we increased the IV diuretics, and as you know, the patient was on dobutamine. So where do we stand? We have advanced decompensated heart failure, low cardiac output, which will result in low systolic mean arterial pressure and low renal perfusion pressure. And we know that this is related to chronic kidney injury because of the high renal venous pressure and the congestion of the organs, basically the kidneys, resulting in the anasarca, the peripheral edema. But going back to the case, with our treatment, fluid balance cumulatively was positive, and urine output dropped over the last hours to about 79 ml. Problem is that we absolutely don't know how to treat these patients because we don't want to see the full picture. So what is the full picture? Well, we all know cardiorenal syndrome, which pathophysiology is not fully understood. It's quite heterogeneous, complex, and it's heart and or kidney failure, either acute or chronic. But if you look at the definition for critical care patients given by Ronco, refining the definition of a complex symbiosis gone wrong. And cardiorenal syndrome is a pathophysiologic disorder of the heart and kidneys in which acute or chronic dysfunction of one organ may induce acute or chronic dysfunction in the other. But what if a patient with known heart failure develops worsening renal function? About 2/3 died within 1 year. So we should be shamed for this terrible prognosis, Wilfrid Mullins would say, because when you have a patient with heart failure, low cardiac output, there will be increase in sympathetic tone, vasopressin, non-osmotic release, and increase in renin-angiotensin-aldosterone system, which will result in a diminished renal perfusion pressure and increase in sodium and water retention. So this comes from what we refer to as forward failure, but this cannot explain what is happening to our patients. So why is this not enough? Because CVP is more important than cardiac index, or the forward failure phenomenon. As studied by Mullins, if we compare CVP and cardiac index to predict worsening of renal function, it seems that CVP, as you can see on the left, the higher the CVP, the more worsening of renal function. And if you look at cardiac index, there was no clear trend showing that lower cardiac index would result in worsening of renal function, the opposite. Is this also true in sepsis? And Mathieu Legrand indeed showed that in patients with sepsis, there is a relation between the CVP and the risk of new or persistent AKI. The higher the CVP, the more the worsening of kidney function. And here you see the relation in this systematic analysis between CVP and baseline creatinine values. So in order to understand what is happening with the kidneys in a patient with decompensated heart failure, we understand the cardiorenal syndrome, so the worsening renal function, the increase in creatinine, which mainly is driven by the increase in central venous pressure. But does this explain the full picture? And maybe it's like an iceberg, that there is a lot beneath, hidden from the eye. So let's go back to our forward failure definition. And we have the salt and water retention, but on the other hand, we've seen that central venous pressure is increased and is related to worsening of renal function. Remember, in our patient, there was pulmonary hypertension and right ventricular failure. So these may then lead to the backward failure, the venous congestion, in combination with the forward failure and the backward failure. Maybe this can explain. It's already a better explanation, but the model is not good enough. Why is that? Because we need to understand what is the culprit lesion for worsening renal function in patients with heart failure. So we're looking for the canary in the coal mine. And we should understand what is happening with the abdomen in patients with heart failure, because this was our patient in the ICU, and the abdominal pressure was 21 millimeters of mercury. Intra-abdominal pressure is the canary in the coal mine for AKI. Did you know that 1 in 4 ICU patients have an ARP above 12? And about 50% will develop abdominal hypertension in the first week. 5% of all ICU mixed patients will have compartment syndrome, which is a pressure above 20, and new onset organ failure with a very high mortality. So you must measure the intra-abdominal pressure in order to identify the problem. And because of the transmission of abdominal pressure to thoracic pressure, this will also result in increase in central venous pressure. And Mullins looked at it and found that 60% of patients with advanced decompensated heart failure have an elevated intra-abdominal pressure. And the higher the intra-abdominal pressure, the higher the baseline serum creatinine. And they found a cutoff of 8, which is quite low. So we need to understand the cardio-renal interactions, but more the cardio-abdominal renal interaction. And that's why the term CARS was coined about I think it's now almost 10 years ago, in a landmark book chapter and paper looking at the abdominal contributions to cardiorenal dysfunction in patients with congestive heart failure. So now we have the possibility to monitor intra-abdominal pressure continuously with for instance, renal device using an existing Foley, and there has been preclinical, and I think now there also has been, this was the preclinical validation in a phantom setup, comparing to other devices with a very good Blunt and Altman. And clinical validation has now been done in laparoscopic surgery. There's another device called the Trauma Guard. There is a regular Foley with 2 more balloons, so in total 3 balloons connected to a smart cable, allowing simple integration, and we are awaiting clinical validation of this device. Another device is the Acurin, which has 2 balloons, 1 positioning, 1 extra for measurement of intra-abdominal pressure. This is sensor integrated Foley, is connected to an active drainage technology of urine into a collection bag that measures the height of the urine produced with ultrasound. And then this separate balloon on the tip of the Foley, we can measure continuous intra-abdominal pressure. And the tablet that is wireless, remotely connected, allows its use in COVID-19 patients, as you can see here in a patient during head of bed obese patients, and when proning, you can see here abdominal pressure is high, urine output low, supine increase in output, and then when put prone, a decrease in urine output because of the increase in intra-abdominal pressure. Here is another view of continuous abdominal pressure. You see when abdominal pressure increases, urine output drops. And by plotting simultaneously abdominal pressure, urine output, and looking at therapeutic actions for congestion, giving furosemide, you see a drop in the intra-abdominal pressure, an increase in urine output, and the creatinine, which is in the KDIGO criteria, is just lagging behind. So maybe it's prime time for continuous intra-abdominal pressure monitoring. You can read this open access paper in intensive care medicine. Recently, Ashish Khanna and colleagues looked at continuous abdominal pressure monitoring in cabbage patients, and you can see that when urine output is high, abdominal pressure is low, and vice versa. When abdominal pressure is high, urine output is lower, and this is for the extubation and spontaneously breathing. So maybe intra-abdominal pressure is the canary in the coal mine, as already stated and summarized in this pathophysiologic mechanism of vascular compression, diaphragm elevation, organ compression, and this will result in a drop in cardiac preload contractility. And so forward failure in combination, as stated, with backward failure and the venous congestion, increase in intra-abdominal pressure, may result in salt and water retention. And fluid resuscitation may induce a vicious cycle leading to abdominal hypertension, worsening of renal function. So maybe in the future we'll have abdominal pressure, but also other biomarkers to identify patients at risk of developing abdominal compartment syndrome and organ failure dysfunction, but also cardiabdominal renal syndrome. Splanchnic capacitance is important. We know that hypovolemia is bad, and hypervolemia may even be worse because you have oxygen diffusion problems. So we need to aim for normal volemia. And as stated, we have these abdominal contributions. We have the abdominal vessels. They have a high capacitance, which is good for autotransfusion and storage pool. High capacitance, but compliance is low. So there is a small range for optimal perfusion pressure. And if because of the fluids abdominal pressure increases, there will be a decrease in superior mesenteric artery flow. And there is a relation between abdominal pressure and flow that could be assessed with indocyanine green plasma disappearance rate. So the higher the abdominal pressure, the lower the perfusion. Another important thing to take in mind is that in analogy to the lungs, where you have the different west zones, the same may hold true in the abdomen, where it's the interplay over the diaphragm of the central venous pressure, inferior vena cava pressure, and intra-abdominal pressure. So we must predict fluid responsiveness before giving fluids, and this can be done by different technologies. And when we have fluid responsiveness on the one hand, can be accompanied with low or high preload, but fluid overload accumulation can be accompanied with low or high index of capillary leak and peripheral edema, either permeability or hydrostatic, as was the case in our patient. In between comes a new concept of fluid tolerance, which is the maximum amount of fluids that can be given to any specific patient, taking into account comorbidities. And this interplay between responsiveness and tolerance will determine the risk for fluid accumulation syndrome. We've seen that in patients with advanced decompensated heart failure, the gut also produces natriuretic peptides like uroguanilin. And these are specific gut alterations that take place not only on the microcirculatory, but also on the microcirculatory, where we see that in decompensation, congestion, there is glycocalyx degradation with about 50%. So what happens in the kidney themselves? Well, good kidneys or healthy kidneys filter a lot of salt during the day, about 1.5 kilogram. If you translate that to big bags of chips, about 137 chips. I did the calculations multiple times just to make sure, but it's a lot of salt that passes normal kidneys. So we have the glomerulus, proximal tubule, loop of Henle, and distal nephron. In patients with decompensated heart failure, all these normal processes will be alterated, resulting in increased filtration fraction to preserve glomerular filtration fraction, but this will result in increased sodium and water reabsorption. So all the kidney dysfunctions, and then there is also inflammation, which was also the case in our patients. Cardioabdominal renal syndrome, increased sodium and water reabsorption. But the question is how to treat our patient with CAS. If we go back to the fluids, we know that maintenance should only be given to cover the daily needs. If there is nothing for us, for water, which is 1 cc per kilo per hour, or for sodium and potassium, which is about millimole per kilo per day, and glucose about 1 gram of glucose per kilo per day. So we've done studies on maintenance solutions, because most of the big fluid trials is on resuscitation fluids. There's not much information on maintenance in healthy volunteers and in critically ill patients. We combined the results of the two studies, MIMOSA and TOPMAST, and found that saline is associated with increased sodium balance. As you can see in healthy, after 48 hours, it's plus 150, and in critically ill, plus 300. Remember, you only need 1 millimole per kilo per day. So it's a lot of salt, and even for healthy kidneys, it takes a lot of time to get rid of it. With the salt accumulation comes the fluid accumulation, and in ICU patients, after 2 days, it's about 1 liter. So patients do get a lot of fluids. On average, 3% is blood, only 6% resuscitation, 25 maintenance, 33 nutrition, and 33 is fluid creep. Fluid that seep into the patient to administer other drugs like antibiotics. Replacement fluids should mimic the fluid that is lost. And in gastrointestinal losses, this may be the only indication of abnormal saline, which contains 3.5 grams of elementary sodium, and we all need 2.3. So when treating these patients, remember the therapeutic dilemma, where each therapeutic option may cause harm. We have to balance the benefits of diuretic therapy and the risks of diuretic therapy. And back to the case, we fixed the patient by giving a combination of diuretics, spironolactone, acetazolamide, thiazide, and indapamide loop diuretics in high dose and continuous, bimetamide, for inhibition of sodium reabsorption, proximal and distal tubulus. Go for renal preservation. We added some vasodilators to increase the renal blood flow and reduce lymph flow. So combination with sodium restriction, fluid restriction, the dobutamine, remember, was already started, and for a short period in time, we had to start CVVH with ultrafiltration, give some milrinone for the pulmonary hypertension, and try with some noradrenaline to improve abdominal perfusion pressure. By all means, try to reduce intra-abdominal pressure and go for renal preservation. Reducing intra-abdominal pressure can be done by evacuating intraluminal contents, intra-abdominal contents, improve the compliance, and optimize fluid administration whilst optimizing systemic perfusion. And you can see the stepwise approach. And if all medical management fail, there is still, if there is a primary compartment syndrome, abdominal decompression. So it's the question, when should we go for surgery when medical management fails? So just one more thing. If we go back to our model combining forward and backward failure. And we assume that the increase in intra-abdominal pressure is the culprit, leading to increase in CVP, portal vein pressure, renal vein pressure. We can now understand the physiology of CARS, but also hepatoabdominal pulmonary syndrome and hepatoabdominal renal syndrome. Remember that ultrasound is the modern stethoscope. By using ultrasound, we can look at renal artery resistive index by calculating peak flow, systolic, diastolic, and Andy Kirkpatrick showed this in a pig model that the higher the intra-abdominal pressure, the higher the resistive index. We can also look at the venous side, and it mimics the CVP tracing. Philip Rolla suggested the VEXA score, looking at hepatic portal and renal venous Doppler. You can calculate the score, and they found that the VEXA score had a much better predictive value to predict worsening of renal function, even better than CVP. So to wrap things up, I hope I convinced you that we need to understand cardio-abdominal renal syndrome, not just by looking at kidney function, CVP, abdominal pressure, but the full picture that will result in sodium and water reabsorption. And remember that intra-abdominal pressure is the missing link to understand why patients with advanced decompensated heart failure will develop worsening renal function. So consider the full impact of hemodynamic alterations of heart failure on worsening renal function. Kidney plays an essential role early on. Central venous pressure is more important than cardiac output. A high CVP is usually related to a high intra-abdominal pressure. Think about the concept of cardio-abdominal renal syndrome, with abdominal pressure being the missing link. Pathophysiology is complex, and the goal is renal preservation by giving the kidney a break, limiting sodium and fluid intake. Future, I think, will learn more about VEXA's score and continuous intra-abdominal pressure monitoring. I invite you to join the WSACS. We have a new members portal, and I also invite you to join the International Fluid Academy.